Good morning. Today, I get to speak to you guys about telehealth and beyond, lessons learned. For those of you who don't know me, I'm Stephen Kareha, and I am the director of the Orthopedic Physical Therapy Residency Program and the director of the Spine Fellowship Program here at St. Luke's University Health Network. I also am a clinical associate faculty at DeSales University in their Doctor of Physical Therapy program. So this is the CME information and the designation statement and the disclosure information. I have nothing to disclose. Today we're going to talk about telehealth, Telerehab. We're going to talk about the vital components of differential diagnostic decision-making via televideo. We're also going to describe how rehab providers can provide a significant value to patients' lives via televideo services. So you're probably in one of three groups right now. You're either in a group that's used televideo, telehealth, and for those of you who are in that group, I want today to help you enhance what you're doing. There's another group of you who haven't yet used it, but maybe eventually plan to if you have to. For those who are in that group, I want to provide some clarity on what telehealth can do for you and what it cannot. And then for those of you who swear up and down you will never use telehealth. I understand that, and I can appreciate that. So today can still be valuable for you because it can provide tools to enhance your in-person visit efficiency and effectiveness. So how did we get here? How am I even talking to you about this? I run an orthopedic residency program and a spine fellowship program, and I do training for people in PT school and post-professionally to make them better clinicians. Well, luckily, I had the great fortune over the past 3 months to mentor a number of people through the COVID pandemic. And during that time, I got a chance to mentor them through a lot of telehealth as well. Additionally, I've had the opportunity to take a course series on telehealth from nationwide experts and learn from the best in the field throughout the country and throughout the world. Also, over this time period, over 50% of my caseload switched to being seen virtually because of massive comorbidities. So you might be asking now, if we are reopening, why does this even matter anymore? What's the point in talking about this now? So I'm going to give you a little story here. Two stories, in fact. One, Pizza Hut and Blockbuster. Both absolute massive behemoths that were doing very, very well. Then Domino's and Netflix came along and rocked the boat. So in both comparisons, Pizza Hut versus Domino's, Blockbuster versus Netflix, each of the former tanked when its biggest competitor went full-scale home delivery. Domino's, Netflix, and tech-savvy copycats triggered not only their own success, but innovation throughout the service industry at large. And as a patient care service industry, and yes, we are a service industry, we now are on the same cusp. Our new delivery model is not only convenient for patients, but it's absolutely crucial for consistency of care, especially during times of quarantine. So how long will it last? How long do we actually have to do this? Despite what we think of ourselves, healthcare is a service industry. Therefore, we are beholden to the same aspects that any other service industry is held to. Ultimately, customer demand. There will be many people who are not interested in continuing with telehealth. I understand that. There will be many others who will demand the convenience of telehealth services. And then there will be a larger group that will request and demand a hybrid approach. Perhaps that would look like a telehealth consultation and in-person treatment, or perhaps an in-person consultation and a mix of hybrid, virtual and in-person treatments that intersperse. Ultimately, there are endless possibilities. So before we discuss any further, let's clarify some terminology. Telehealth. This essentially is the collection of means or methods for enhancing public health, healthcare, and health education delivery, and support using telecommunications technologies. Telerehab is a little bit more specific. This is looking at the delivery of rehab services over telecommunication networks and the internet. Most types of these services fall into one of two categories. 1, evaluation. 2, intervention. All right, so we got that out of the way. Effectively, telehealth is the large-scale term. This encompasses telerehab, telemedicine, public health, health education, and a lot of other stuff. Now, as we move forward with telehealth or telerehab, we're not talking about a glorified home exercise program, home program, medication checkup. That's not what we're looking at for a spot check. We're looking at real diagnosis and real care for patients. So let's think about how we do this for a moment. What value do we actually provide for our patients? So if you're a hands-on dominant therapist, I can bet, based upon surveys that have been taken, that this is probably what you're thinking. Yeah, history and physical exam is good. Your communication, guidance, and accountability, yeah, it's important too. And yeah, the exercise is important too. But man, the hands-on therapist, that's the hands-on treatment is the thing that fixes your patients. If you're a strengthening dominant therapist, yeah, the history and physical exam, that's important. Communication, guidance, accountability, and hands-on treatment, that's all okay. But the strength and conditioning, that skill in strength and conditioning is the thing that provides the patient with value. Well, luckily somebody surveyed patients and they found out really they're looking for all. The things that the patients are looking for is to know what's wrong, to communicate that and provide that guidance and accountability. And yes, they want therapeutic touch and they want to be progressed appropriately. But here's the either frightening thing or maybe positive thing, depending on your spin. What do patients value most out of everything? Convenience. There's a study in 2019 that showed that 51.3% of consumers say convenient healthcare is the most important factor in their choice of providers. It matters more than brand reputation, more than quality, and more than interpersonal interactions that they had with clinicians, and even more than insurance coverage. Think about that for a moment. We worry so much about insurance coverage, but convenience matters more. The study showed that 80% of Americans chose their care strictly by how convenient it is to access services. So access is key. Now, while telehealth provides us that access, I think it's also important to understand what are the greatest skills of rehab professionals. Is it hands-on care? Is it what we think, what we do, what we diagnose? Is it the progression? What is it? Well, the studies show that really the biggest skills that we have as rehabilitation professionals are first, asking the right questions and follow-up questions. 2, knowing what and when to do whatever you're planning. So effectively developing a plan to achieve what the patient wants. And yes, manual therapy or tactile cueing, those are key as well. Now with that, understand that that first component of asking the right questions is key, because 80% of diagnosis comes from patient history. And you might say, well, we need to do a physical exam, and I agree we do. When compared to an MRI exam for the shoulder, 75% of patients were accurately diagnosed by history alone, and 12% of patients received an incorrect diagnosis, not because the hypothesis was wrong by the end of the history, but because of confounding factors that were discovered during the physical exam. So actually the diagnosis was correct prior to the physical exam, but confounded by the physical exam itself. There was another study in 2017 that found that there was a very high correlation in diagnostic accuracy between in-person and telehealth. So, diagnostic decision-making does, at least 13% of the time, require physical exam. But the rest of the time, it may not. Because again, 80% of diagnosis is made during the physical exam. Now, interventions though. Well, great, we can make a diagnosis by telehealth, but what about interventions? What can we actually do? A study in 2017 found the most effective interventions are the 5 that are listed here: neuromuscular reeducation, therapeutic exercise, patient self-management, psychosocial intervention, and manual therapy. So what can be done in person versus virtual? Let's look at neuromuscular reeducation. Yeah, it can be done both in person and virtual. Therapeutic exercise, both in person and virtual. Patient self-management, in person and virtual. And I'm going to argue a little bit that patient self-management is enhanced with virtual because it puts more onus on the patient. Psychosocial intervention, it can be done in person and virtual. Manual therapy, I'm not going to blow smoke here. It cannot be done virtually. I get that. You can teach the patient to self-manage through a self-applied manual therapy, but you cannot provide manual therapy via virtual therapy. So it all boils down to the value that patients receive that come out of the outcomes and convenience. There was a study in 2016 that found that the outcomes in specific diagnostic categories and for certain people is equal to in-person care. Now, this isn't to say that all therapy and all intervention should be done virtually because it's equal. I do disagree with that. But in patients who have the ability to do it by themselves and take instruction well virtually, will do equally as well virtually as in person. It also has to do with personal equipoise, as Dr. Kushner had mentioned in last month's Grand Rounds. The belief of the provider providing the care is paramount. It cannot be overstressed that if the provider does not believe it will be effective, it won't. The other thing is convenience. It's a significant decrease in the amount of time it takes a patient to get ready, get to the office, receive the care, leave the office, unwind, and then resume their day. They're able to just hop on, receive care, and hop off. So it saves a significant amount of time. There was a study that actually showed that the average time it takes is about an hour pre-visit and an hour post-visit between travel, preparation. So that's it, with an hour appointment, that's a 3-hour time block. This cuts it in a third to maybe 5 minutes before or 5 minutes afterwards. So with all that information, yeah, it can be useful, but how do we enhance it? How do we really help our patients? How do we enhance virtual care? And I will say in person as well. How do we enhance in-person care as well? So there's 5 major points here. First, to enhance virtual care, you want to set yourself up for success. You want to reduce pressure on yourself, set clear expectations, anticipate objections, and keep it simple. So setting yourself up for success, you want front lighting. As you can see from the picture here, the picture on the left has a window in the background, which effectively provides backlighting. This darkens you. It makes it so that all you see is a silhouette. The picture on the right is the exact same person, but with front lighting and with a plain background. It's a whole lot easier to see that person. Eye contact. You want to look at the camera, not down at your notes, not at your documentation. You can see right now that my eyes are not staring at you, and now they are. This may seem odd because you're staring at a little dot on a laptop or a little camera on top of your computer. But understand that the patient looking back at you is seeing your eyes very clearly. You can tell when the person is looking at you versus not. So make sure that you're talking to them like you would normally do in a real life situation, just looking at the camera as their eyes. And appreciate space. You want to make sure you have the appropriate amount of space for both you to move and demonstrate whatever it is that you need to demonstrate, whether that's testing, whether that's interventions. It doesn't matter. Make sure you have enough space, but then also make sure your patient has the right setup. If you anticipate needing them to get down on the floor or on their bed, make sure that they have that available. If you anticipate them needing to show you how they move on stairs, understand that as well. Or if you need to see their desk space, their office space, make sure you have that, tell them that ahead of time. One of the greatest benefits of telehealth is you can see them in their own environment. So you're no longer guessing their ergonomic setup. You can actually see their ergonomic setup. Also, understand the laws. The patient must be physically in the state that you are licensed in. You do not have to be. So that's one of the really interesting things about telehealth. As long as the patient is physically in the state that you are licensed in, it is allowed by law. Now, the caveat is reimbursement. And of course, this is not legal advice by any stretch right now. As of this moment, most insurers require that you are physically in a location that is accredited by that insurance company by your contract. So that's one of the problems with doing it from home or an alternate location, because if you're seeking reimbursement from insurance and you're not in the office that is accredited under that contract, there will be a problem with reimbursement. So keep both of those in mind. The legal aspect, if you have a patient that goes on vacation, you need to wait till they come back to the state, unless there is a waiver due to an epidemic or a pandemic. Reduce pressure on yourself. listen. Listen to your patient. Be compassionate and understand that most patients really just want guidance and accountability. They want guidance. They want to know what's wrong. They want to know how to fix it. And they want to be held accountable so that they can achieve what they want. And I'm going to give you a little hint. Most patients don't simply want pain relief. Otherwise, they'd go to a medication counter in a grocery store. They want to be able to get back to their life. They want to be able to move. Movement restores quality of life. So ask them what they want. Do not apologize for not being able to see them in person. And there are things you can't do online. So don't apologize for that either. Understand that everything we do has a trade-off. Remember, telehealth has a huge pro of convenience and a con of no therapeutic touch. And remember, this is a special service for the patient. You are helping them. Understand that. Also understand that this special service, when we proceed to move out of this pandemic, some patients or some companies, some providers will completely cease with virtual therapy, virtual rehab, virtual diagnostics. They will, because they don't like it. But if you continue it, you are providing that special service for the patient. So it is a business opportunity. Set clear expectations. So an example of this is we have this great new service where we can see people without even needing them to come in the office. We can work with you to figure out what's going wrong and come up with a plan to fix it. Many times we can fix it completely through virtual therapy, whether that is additional testing, seeing me in person, or seeing another provider through telehealth or in person, and we can set that up for you as well. Ease fear. Remember, anytime you go into a new situation, there is going to be some level of fear. Some people get over that very quickly. Some people have immense anxiety about going into a new situation that they have not experienced before. Ease fear. Tell them what you're going to do and what you can and cannot do via telehealth. You can diagnose them. Yes, you can provide interventions that will help them get better. But you do need to be more willing and readily willing to refer the patient for an in-person visit or for further testing, since you can't perform some physical examination tests that would normally trigger a specific referral. So you can't do deep tendon reflexes to determine if they're neurologically impaired. So if you get a hint that they are neurologically impaired with an acute radiculopathy or an acute onset of neurologic symptoms, you do need to refer them. Even if you are wavering and you're not sure, that is the time to refer. And you may feel guilty about that because you couldn't rule that out, and normally in the office you would be. It's okay. People do understand, and there are limitations. Then once you do provide the patient with options and tell them, hey, this is what I can offer you and this is what I can't offer you, let the patient make the decision based upon what is best for them. Remember, it's not about you, it is about your patient. Exceed their expectations. Give them the understanding of what you can help them with and let them make a decision. With that, Also, anticipate objections. People have a very short memory, especially when it's a long-term goal or a long-term interest. Especially if somebody comes in for back pain, they might come in because their biggest concern is they can't care for themselves anymore and they need other people to help them. And they don't like that. They want to maintain their independence. That's really what drove them to get in the office in the first place or on virtual care. But a couple of weeks from now, they're just focused on the here and now. So they start talking about the amount of pain that they're having with bending, neglecting the fact that they are already able to brush their teeth without pain. They're able to go up and down stairs without pain, but they can't lift 50 pounds still. So make sure you consistently remind them what their chief concern was that they said. Not what you conjured, but what they said and their desired outcomes. What is it that they want? So I'm going to give you a little analogy here. Remember back when when the quarantine began, for the first 2 weeks, people were really understanding and, they stuck to their guns. After about 2 weeks, people started getting antsy. They started questioning, why are we doing this? What are we doing it for? I don't see it around me because we've been quarantined, so it must not exist. So they started questioning it, and it has taken a lot of people a lot of time and energy to help others understand why they were doing what they were doing. So that ends up being your job in the clinic or via telehealth, but it is imperative with telehealth. Help remind them what those desired outcomes were in the first place. And keep it simple. People remember the first thing you say more than anything else. Help set the stage that you really did listen and understand the patient's concern by starting your explanation with your recommended solution with why. For example, to give you the best chance of getting back to running and playing with your grandchildren as fast as possible, I need to see you for 6 visits over the next 4 weeks. Or to give you the best chance of getting back to running and playing with your grandchildren, I need you to go see Dr. X for another examination. Or I need you to have further testing in the office. And continuing with simplicity, people only remember 7% of what you say. So choose your words wisely. Understand that 7%, if you see them for 45 minutes, that means they will remember 3 minutes of what you said. 3. So simple, clear explanations, ideally in story format, helps them understand the problem a whole lot better, how it began, and how to fix it. So I'm going to help put this into an actual patient case scenario to help put those things into reality. So first, set the expectation. Today, I'm going to ask you a bunch of questions. I'm going to have you do a lot of movements to help figure out what's wrong and what can be done to help you. I'm going to ask the patient, what are your greatest concerns about the problem that I'm seeing you for, about your back pain, about your knee pain? This helps you obtain the intrinsic motivation to help you understand the patient. Where are they coming from? How can you help them most? What does success look like? This helps you know where you're going. Asking patients their goals is kind of crazy. People train for years to learn to set goals. Yes, it does come easy for some, but not for the majority. You ask somebody their goals, their first answer is, people don't know. And if their first gut reaction is pain relief, that's accurate, but that's not the underlying what they really want. What is their vision of success? And then to help you get there and help you understand how the patient is going to perceive it, because yes, perception is reality. Ask them, what does progress look like? Or what does an early win look like? That'll help you set short-term goals. What is progress in their eyes? And some people, it may be unrealistic. Some people, it may be very realistic. It may be extremely eye-opening to you. And again, these three questions can be asked in person or virtually. I would argue they are vital virtually to help you help your patient. Now it's time for the history. This is where the magic happens. Remember, 80% of diagnosis comes from history. And don't forget your systems review. Most of the systems review can be ruled out via history. And remember, your number one skill is asking your follow-up questions. So if they say something that takes you down a path of concern, make sure that you follow up with that to rule out any competing concerning diagnoses that would require referral. For your systems review, you can have them use a home blood pressure cuff. You can have them take their pulse. You can teach them how to use their fingers to take their own pulse virtually. And then the physical exam. This is very specific to virtual, and I understand that. So I'm going to help break this down for those, because for those of you who are thinking, well, I can't do a physical exam virtually. And yes, there are some limitations. You can do a gait analysis. Actually, sometimes a virtual gait analysis is easier because you can slow things down, you can speed things up, you can change it. You can do a squat or a lunge or a lateral step down, watching them move from against gravity. You can look at their balance. You can assess their balance. You can watch them do heel raises or range of motion or a slump test for the lower quarter. For the upper quarter, you can look at their range of motion. You can look at neural tension. You can look at how they push and pull objects. All those are large movement screens. I'm going to step aside and mention there was a study back in 2002 that showed the difference between the advanced specialist and the novice rehab professional. One of the major differences was their ability to use their observational skills. In a virtual physical exam, it is reliant upon your observational skills. So in this case, you actually get a chance to show that expertise even greater. Endurance. You can test endurance by doing a 5-time sit-to-stand, a 30-second sit-to-stand test or push-up test, or many others. You can teach the patient to do that virtually and safely. It might not be safe for a particular patient to do a 6-minute walk test, or it might. It depends on the problem. It depends on the state of the patient. Body mechanics. As I mentioned earlier, you actually get to see them in their own ergonomic environment. Take advantage of that. Make sure you watch them to do the activities that they report are difficult. You might be able to find an extremely simple fix because of your observational skills and your ability to ask follow-up questions. Posture. We do this with observation in the office anyway, so there's no additional difference with virtual. Palpation. No, you can't reach through the screen and palpate, but you can teach them to self-palpate. Is this the same? Absolutely not. But is it useful? Yes. People have the ability to feel. As long as they are not insensate, they can self-palpate. Range of motion. As I mentioned before, active range of motion, you can check. You may choose to use minimal, moderate, and maximal restriction levels just due to the virtual nature. But also understand that visual observation of range of motion is within 5 degrees of goniometry in most cases. So using range of motion measurement is not off the table. And there are some virtual therapy platforms that actually have digital goniometers too. Passive range of motion, if it is imperative for that particular, to diagnose that particular problem, you do need to refer for an in-person visit. Because passive range of motion, unless there is another person that can move them, is not possible independently. Strength. You can watch them move against gravity. You can watch them apply resistance to themselves or lift objects. Again, putting them in their own environment gives you a unique opportunity to see what really is the problem. You can watch them if they have a problem reaching for their toothbrush because their back hurts. You can have them take the computer or their phone and watch them do that. Maybe they just temporarily need to move the toothbrush closer to them. Maybe it's something greater than that. And then further diagnostic testing. You should demonstrate the physical exam procedure first, such as repeated movements. You can then turn and show them how you want them to move. The drop arm test, raising your arms over your head and slowly lower. Scratch test for the elbow and wrist. Any of these diagnostic tests can be performed by demonstrating them and have the patient respond. If the patient is not able to perform and repeat something that is key for diagnosis, yes, you do need to refer them for an in-person visit. Once you come up with that multifactorial diagnosis, that problem that you need to address, you need to decide whether to treat, refer, or refer and treat. Just remember, since you're not in person, you will need to be more readily willing to refer that patient than you would be in person because you can't perform some specific testing. So once you have that multifactorial diagnosis, maybe your choice is, hey, I can help you via telehealth completely. I can provide neuromuscular re-education, therapeutic exercise. I can help you manage it yourself. I can provide that psychosocial intervention. Maybe you decide, you know what, you really need hands-on care. So you refer them to an in-person visit. Or you may refer them to another provider because they need to see a different profession or a different professional. Or maybe you need to refer them for radiologic or other diagnostic testing. Or maybe it's a combination. Maybe they do need some hands-on, but they can do other via telehealth. Maybe they need further testing and other professional care, multidisciplinary care, and they need to see you via telehealth. So keep that in mind. And then at the end, whether you're in person or virtually, confirm the patient understands. I know this sounds simplistic, but ask. I will tell you what I hear most from people, providers of all levels, is they're rushed. They have very little time. So they really quickly ask, do you have any questions? If somebody asks you, do you have any questions? What is your answer going to be? ultimately your answer is going to be no. That is the gut response of most human beings. It's a conditioned response. If you truly want to understand the patient's level of understanding, you need to ask in a way that encourages a response, an honest response, a disarming response. So asking it in this way, what concerns do you have about completing the plan of care we discussed? And then pause. Let them process it, because more than likely they have never been asked this before. So they will have to think and process it. If you do that, patients may still say, no, I'm good. But they may ask you a very insightful question that may help clarify and help them understand the broader spectrum and help them get better faster. So ultimately, the lessons that I learned through the past few months of telehealth and telerehab is really the principles of good telehealth care are not much different than good live healthcare. Set yourself up for success. Reduce pressure on yourself. Understand there are limitations. Set clear expectations for both yourself and for your patient. Anticipate objections. Help your patient understand and keep it simple. So, what questions do you have? I encourage you to email me with questions that you have about this presentation. I would be happy to help you. Attached are my references. And I thank you very much for joining me today.